I always ask about symptoms in the area and ask to look to make sure that there's not something that they just don't feel comfortable bringing up on their own. I just take that stigma away by just putting it on the table myself.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, how are things going? I've been thinking a lot about, I do a lot of thinking every time we start a podcast, don't we?
Hey, it's good to think, my friend.
I'm a big thinker here, but I've been thinking a lot more lately. I think regularly too, but anyway, okay, I digress. But I've been thinking a lot about the fact that we're dermatologists. We look at a lot of skin, but every once in a while, we need some specialized help in how we look at the skin, wouldn't you say?
Yes, I think we do a lot of things in medicine that are a little uncomfortable. We develop this intimate relationship with our patients, and they share a lot with us. They share their history, they share their experiences. And in dermatology specifically, they really have to get exposed. And one of the most I don't want to say difficult, but a tricky part of every visit is the genital exam. And today we wanted to really dedicate some time to discuss this. It is going to be a very difficult episode for you and I, my friend, because puns are not part of the discussion here. It is going to be tricky. So we thought instead of having two guys try to stumble with words over this, we will bring an expert. Shall we introduce her?
Absolutely. Let's do it. And I think this is a really important topic. So we have Dr. Audrey Rutherford. She's a board certified dermatologist practicing out in the Denver area, actually in Cherry Creek. And the reason that's cool is because I actually stayed there when I did my rotations when I was a medical student out in at University of Colorado, Denver, when I was out there for my medical school rotation. Anyway, Audrey, welcome to the podcast. We are super excited to have you on. We know you're an expert in this area of gynecological health, so thanks for joining us.
Thank you. Thank y'all for having me.
Of course. And Audrey, I want to start with maybe in the beginning, maybe it's stating the obvious, but I think it needs to be stated. Why is it so important that dermatologists, maybe physicians in general, if appropriate, do a thorough vulvovaginal exam and really address some of these issues?
Well, it's important particularly for dermatologists because we're the experts when it comes to skin. So we're looking at people's, in between their toes, we're looking at their scalp, we're looking everywhere. And a lot of conditions that we expect in other parts of the body can also show up in the genitals. And being the skin specialists, we should be still looking at this because it's still considered skin. And, gynecologists kind of get put into this category where they're the ones that are supposed to be looking, but they don't have the same skin training that we do, and they don't have the same level of expertise. And so there's things that can kind of fall between the cracks. And so it's important to be able to look at those places because anything from like skin conditions to cancers can pop up in the genitals. So you don't want to miss it.
So what do you think, Audrey, despite all the medical training, and we are in 2025 at the time of this recording at least, why is it still so difficult? What are the barriers that you commonly encounter, that you hear about? Because you've been lecturing about this all around. What are some of the common barriers that physicians mention to you? We kind of understand why it may be difficult or, uncomfortable for the patient to be exposed like that and examined. But what do physicians bring up to you?
I think the two biggest things that I hear from other providers are things like not having enough time to do an adequate exam. And then when you are doing the exam, not knowing what you're looking for. And so not knowing what's normal or not. And so those are the two biggest barriers that I hear kind of from the provider side. But I also think there's a big barrier just on patients feeling comfortable. So it kind of goes both ways.
So perhaps you can tell us what are some of the common skin conditions, because we're trying to establish why is it important to really do vulvovaginal exams. Perhaps you can tell us some of the conditions, so for both the clinicians who are listening, but also the general public listening to this can understand why is it important to perform these exams as part of a good physical exam with the dermatologist.
Well, number one is like the life-threatening things, obviously. And so even melanoma can occur in the genitals. And the actual outcomes for patients who have diagnoses of vulvar or vaginal melanoma, for example, have really horrendous 5-year survival rates in like the less than 50%. And it's typically because these are found so late and late stages versus like in melanomas found in the rest of the body. The rest of the cutaneous melanomas have survival rates now that are, pushing in the 90s percentiles. So because people aren't looking and patients don't necessarily know to do their own exams, they're not finding things, patients and providers are not finding things early, and it can lead to just this horrific melanoma survival rates that have been reported. That's obviously like the most scary stuff, is the things that are going to really shorten patients' life expectancy. But there's other conditions that can occur that can also lead to cancer. So things like lichen sclerosus, it's incredibly underdiagnosed and mainly underdiagnosed because of lack of exams. And then that in and of itself can lead to vulvar carcinoma. And then quality of life also is so important. So things that are even affecting patients like atopic dermatitis or genitourinary syndrome of menopause, those things are very important as well. And patients often don't like to bring them up because it's awkward and uncomfortable. And you can do a lot of good for patients if you're just willing to make that part of your standard exam. Like, I'm looking in between your toes, I'm going to look at your vulva. And offering up that level of trust, making it just part of your own spiel, makes patients feel more comfortable too and much more willing to actually allow you to do exams.
Thank you. I think it's really important that we bring up these the need for the exam and explaining that there's some things that really the trained eye can really do this. And as we all know, part of it's called the practice of medicine, because you get better as you do this. And if you don't do this, then you really are losing a skill that you may have gained in residency. And if you don't keep practicing at it, I think that's one of the reasons it's really important. And important to see a lot of normal, right? To really see and observe quickly the abnormal and the subtleties, and early diagnosis, as you mentioned, in some of these conditions is really critical. Can you maybe give us your approach? What is your usual spiel that you mentioned to maybe help other dermatologists and healthcare provider who need to perform a vulvovaginal exam and may feel a little apprehensive?
Yeah, and it really does take a little bit of practice in explaining both to your staff, because sometimes that's kind of setting the stage. If your staff that you're working with is not used to having patients get completely undressed, including their underwear, for total body skin exams, that can be kind of a barrier. And so explaining it both to your staff so they are prepared, then they can tell the patient to actually get completely undressed. And then when you're doing the exam, I will have patients, if for whatever reason they didn't remove their underwear, I will say, I'm going to look from head to toe. That includes your genitals. I obviously give patients agency and tell them they do not have to let me look, but particularly if they haven't had anybody look there in a while, or if they've ever had any sort of skin condition, or including like psoriasis or eczema, or any sort of malignancy like squamous cell carcinoma, melanoma, condyloma, those things, I try to explain to them why this is so important for me to look, and make it just it really doesn't even add that much time to the exam itself. So I'll go head to toe, start with the scalp, work my way down. And then before having patients go to their back, I'll have them lay back and essentially do a genital exam, either using stirrups or just completely supine, and like a frog leg position. And you can get quick, easy exams done that way. I've diagnosed in the past month alone 2 women with lichen sclerosus on a general total body skin exam that had no idea they had it. And that's two people who asymptomatic. So there's a lot you can do and a lot you can intervene in just by taking that extra minute and a half to lay the patient back and to look at their genitals. If I'm getting pushback from patients, like if they're like, I don't feel comfortable with it, I'll say, well, we don't have to do it this time. I understand that you're not prepared for it, but this is part of your skin. This is important. So next time, let's plan to do that. And then if they're coming in for anything in particular, like a skin condition, like if they have psoriasis, like I said, or eczema, I always ask about symptoms in the area and ask to look to make sure that there's not something that they just don't feel comfortable bringing up on their own. I just take that stigma away by just putting it on the table myself. So.
Yeah, thanks for sharing all that, Audrey. And I think it's really nice to get an overview of how you approach this. Let's talk some conditions, though. I really want to delve into some of the ones that are really challenging for us. And I know that, there are quite a few that can be challenging. But can you speak to a little bit more about what are the common conditions that you end up treating that are maybe chronic? And if you can also mention lichen sclerosus, because that seems to be one that I actually see a lot of my patients for this quite frequently. And many of them, they're just happy to come see any dermatologist because it takes them so long to get to us. So I'm curious if you can mention, first, what are some of the common conditions that maybe we should all be thinking about? And then if you can also touch on lichen sclerosus.
Yeah, definitely. So most common, I would say, is actually genitourinary syndrome of menopause. And that's just because it's essentially a natural part of a woman's life cycle. So it's kind of even hard to consider it a condition, more of a finding of skin changes and symptoms that occurs naturally. And so I'd say that's probably the most common. And that can result in things like itch and pain and tenderness and dryness, and then can sometimes be tricky because it can lead to skin changes that might be confused with lichen sclerosus. But that is definitely the most common one. And I'm also somebody who's not necessarily afraid to encourage dermatologists to put women on a low dose local vulvovaginal estrogen to help with those symptoms, because you can actually make a huge difference in quality of life if you're willing to treat those patients. Other common findings in the genitals that are other than, obviously there's going to be like seborrheic keratoses and angiokeratomas and those kind of things. But more of the rashy stuff would be atopic dermatitis can definitely occur pretty frequently in the genitals. And then because of the sensitive skin in that modified mucosal membrane, as well as like the mucosal membrane, you can have irritant and contact dermatitis, either allergic or irritant, pretty easily as well. And a lot of times that just takes a little bit of hygiene intervention and discussion. Psoriasis is much more prevalent than I think we often are aware of in the genitals for our patients, just because, again, they don't like to bring it up. But you can see it pretty commonly for vulvar skin. And then lichen sclerosus and lichen planus are pretty common as well. Lichen sclerosus, I do tend to see a little bit more often, but lichen planus is sometimes the mimicker, because it can look like lichen sclerosus. It can look like other sort of vesicular-bullous diseases. It can be kind of a tricky one to determine. But lichen sclerosus, I'd say, is the one that I'm personally most passionate about because of that cancer risk and making sure that patients are getting appropriate treatment and preventing that cancer risk. So topical steroids are still the mainstay of treatment for that, because we don't want the chronic irritation that comes on from the LS to turn into the SCC or differentiated vulvar intraepithelial neoplasia, which then turns into the SCC that can affect it. So most common, I'd say, is those few skin conditions, but most concerning to me is that LS.
Thank you. I want to go back to this topical steroid treatment for lichen sclerosus, because I know a lot of patients nowadays are well educated and they ask very good questions about using high potency topical steroids. Can you, in that area specifically, and can you review for us why it's important, and are there new alternatives? You said this is still the mainstay, but are there other alternatives? So why is it important? What is the evidence on the side effects, on atrophy, even ulceration in these in that area of high friction, and then go maybe into some alternatives if you wanted to try those?
Yeah. So the thing that we have to remember with lichen sclerosus is think about like the physiology of it. And so what occurs is you get essentially hyperkeratosis and thickening of that stratum corneum. And that's going to be your rate limiting step for any skin condition in regards to absorption of topical products and topical steroids. And so in lichen sclerosus, that thickened stratum corneum really inhibits any sort of absorption more so than normal non-lichen sclerotic skin of the vulva. And so patients, I try to explain this to patients, like if you have a condition, like, say, heaven forbid, you have cancer, you're going to need chemotherapy or a cancer medication. If you have lichen sclerosus, you need an appropriately potent topical steroid on the vulva. I wouldn't give somebody who doesn't have cancer a chemotherapy. I wouldn't give somebody who doesn't have lichen sclerosus such a high potency topical steroid. But whenever you're utilizing the topical steroid in an appropriate way, in the appropriate location with the appropriate frequency, you're not going to have those scary side effects that are all over the internet. And the studies have actually shown that the frequency of like the steroid atrophy and steroid dermatitis and things like that in settings of patients with lichen sclerosus is incredibly low. And even in those patients where it does occur with the appropriate monitoring, so say, if you're seeing a patient every 3 to 6 months or whatnot, if you start noticing those changes and you appropriately titrate frequency or potency of that steroid down, those changes have been shown to be reversible. And so I know there's a lot of fear about topical steroid and side effects from that. But for lichen sclerosus in particular, the data does not support those fears. Whereas the flip side is true. Patients who are not using topical steroids appropriately have actually been shown to have a much higher risk for developing cancer. And so it's really trying to educate patients on what we know to be a fact, which is that untreated lichen sclerosus can lead to cancer versus a theoretical fear of topical steroid being inappropriately used, leading to steroid atrophy.
Thank you. That was excellent. Do you have any tips on are there any tips on how to apply medications in that area? I think that this is something that maybe we skip over in residency. We hear a lot about applying medications under occlusion, for example, and in skin folds specifically. And this area is always covered with tight clothing. Usually, you kind of get that extra benefit, I would suppose. But do you have any specific recommendation for your patients on how to apply these medications? A, to improve efficacy, and B, to avoid the side effects if it kind of spills over to unaffected area?
Yeah, and that's kind of the key there, is like avoiding the side effects when they spill over, right? So usually if I'm seeing a patient who is having side effects from steroid overuse, by and large, it's because they have been either using too much or putting it in the wrong place. And so, if someone's been given clobetasol, for example, or a topical high potency corticosteroid and not been shown where on their body to use it. And most women aren't looking at their vulvas frequently. And so they may not know what part of their skin of the vulva is being involved. If it just says apply to the vulva, they may just, smother it on without willy-nilly, without really thinking about it. And that's when that steroid atrophy can occur. And a lot of that's because it'll be put on the labia majora, which is that hair-bearing portion of the vulva. And that is a much higher likelihood of developing steroid atrophy in comparison to that modified mucosal membrane of the labia minora and the clitoral hood. It seems to be a little bit more resistant to topical steroids in those areas. And so what I'll do for a patient is have them either spread, in their frog leg position or with their feet in the footrest. And then I'll give them a hand mirror and use actual Vaseline or petroleum jelly and take the amount that I want the patient to use, which for the vulva, so the labia, if you're treating the clitoral hood, the labia minora, and like the perineum area, you really only need about a lentil sized amount. And then if you're including the labia majora, you can go a little bit more than that. But typically a very, very small amount, less than a pea size for sure, for the vulva. And then I will show them with that Vaseline or petroleum jelly on their own body exactly where I want them to apply it. And then I will also have them, I'll do a photo for my medical chart. And then if they'll let me, I will print it out for them, or I'll just show them on the iPad and have them look at their own anatomy of where I want them to apply that topical steroid. And that way they have been shown on their own image, on their own body, and in person how much I want them to use. And that gives them the ability to kind of reference it. And when they first start using it, if they've never looked at their vulva, I'll encourage them to get a hand mirror at home to do that, or even set up a mirror on the ground and kind of scooch their booty up to it to be able to see exactly where they're putting the topicals. And that can be helpful right off the bat, just to get people kind of used to the areas that I want them to apply it.
That's excellent. Thank you, because I think a lot of us are probably doing exactly what you said. It's just just put it there, twice a day. And where there? What do you mean? And that can be very confusing.
Hey, Hadar, can I jump in here with a question, actually, just on this note? When we're talking about lichen sclerosus, for example, or any of these sort of inflammatory diseases, do you ever utilize devices? I know they're not covered by insurance, but I've seen more and more, and even myself, I've had experience using things like an erbium YAG laser, which at first blush, you might think, how the heck's that going to work? But I've seen some of my patients actually get tremendously better with it when we just gave it a shot and tried it. Or like microneedling with radio frequency. I mean, I have no idea why these things would work, except maybe they're increasing the native tissue integrity. I have no idea, but do you have any experience with that, Audrey?
Yeah. So the current guidelines are actually recommended not to utilize those, and there's a kind of a twofold as to why. They're typically not covered by insurance. They typically are more invasive procedures or devices or what have you. And the evidence to date has not shown any equivalency or benefit in comparison to appropriately dosed topical steroids. And there's been randomized controlled double-blinded sham trials that actually looked at CO2 laser, and that actually didn't show any difference. There are newer studies out that are also looking at, okay, if it's not better on its own, does it improve perhaps steroid absorption, which is maybe why it's helpful, because it's helping actually the penetration of the topical steroid getting in. But as of now, the data is not supportive of any of those lasers or procedures or anything like that. I think eventually, as time goes on and we get better data, things may change in that regard. But I think it needs to be a lot of coming at those studies that are kind of looking at that needs to be done with a really careful, critical eye, because a lot of them that are touting benefit have kind of questionable retrospective skews and no like objective or histopathologic evidence behind it. And so as time goes on, if there's more robust studies, perhaps that will change over time. But based on the data that I have seen thus far, and based on the recommendations of many of the vulvovaginal dermatology and disease international organizations, such as the ISSVD, it's not currently recommended.
Yeah, no, that's really great to hear. And, guidelines are always going to be, I think, very focused on the level of evidence. I mean, we see emerging case reports. I think there was one randomized controlled trial showing Nd:YAG, Erbium-YAG combo against topical steroids. They were like very close to each other. But I feel like you're saying, these studies are newer and they don't always get incorporated into, as with everything, into guidelines right away. And probably the guideline committees are waiting to see more and more studies emerging. So I think your point's well taken that we just need to see more studies come out before they're going to include these into guidelines, I would imagine, at this point.
Yeah. And I think the issue is too, with lichen sclerosus in particular, something that both patients and clinicians need to get on the same page about and understand each other is, me as a physician, I want patients to feel better, obviously, but I also want to control their disease in regards to activity and scarring and things like that. And then also prevent cancer. And the only thing that's been shown to do all of that are appropriately dosed topical steroids. Eventually, perhaps some of the more symptomatic treatments like lasers and things like that will be looked at in regards to, can they prevent malignancy progression and scarring progression and things like that. But because we're not there yet, it does give me a little bit pause to recommend those things for my patients, because they are so expensive and because we don't know what the long-term outcomes are going to be. So I try to, I'm obviously never going to tell a patient absolutely no, you can't do something, but whether or not I'm going to necessarily recommend it based on what the evidence shows to date is going to be a little bit different.
Thank you. Audrey, I wanted to switch gears perhaps and maybe help some of our patients, because one of the common questions we get a lot of times is, what do you recommend for daily care? And I think all of us have a spiel for the face and kind of the body and sunscreen and moisturizer and all these good habits that we all should have. But I think many of us may skip the vulvovaginal daily routine care, if there is such a thing. Do you have a spiel that you have for your patients, a handout, or some other recommendations that you make for them for just the healthy daily routine? And maybe you can also address, you mentioned changes that happen around menopause and aging in general.
Yeah, the beauty of the vulva and the vagina is that it's pretty it takes care of itself. And so you really don't have to do too much. And so typically what I'll recommend in regards to hygiene is, if it's mucosal surfaces, you don't need any sort of soap. You just need water in your hands. I recommend for toileting to just use plain toilet paper or a bidet. I don't recommend any sort of wet wipes or anything like that, because there's preservatives and whatnot that can be irritating to the skin. There's no douching that needs to be done. That's actually been completely debunked. You increase risk for sexually transmitted diseases and bacterial vaginosis and pelvic inflammatory diseases with that kind of stuff. So it's definitely don't do that. And then if patients are, postmenopausal or are lacking estrogen, or are just tend to have a little bit more drier mucosa because of atopic dermatitis or Sjogren's syndrome or something like that, I will recommend just a bland emollient. So, the same thing that we would recommend for eczema in kiddos is pretty much what I would recommend for the vulva, or even just Vaseline, something occlusive just to help with transepidermal water loss is also helpful. So it can be really boring, and that's all they need.
No, simple is good. Simple is good. We like simple here. So you mentioned guidelines, and I think it's important to maybe give our listeners some resources. What are good resources that dermatologists, other skin clinicians can refer to? You mentioned some organizations. Perhaps you can mention those and what they do and why are they good?
Yeah, so the first one I mentioned was the International Society for the Study of Vulvovaginal Diseases. It's an international organization made up of gynecologists, dermatologists, pathologists, microbiologists, pelvic floor physical therapists, essentially anybody who takes care of women's vulvas or vaginas. And that's a great organization because it comes together with all the different big thinkers across the world and all of the research across the world and brings it into one group that's going to make recommendations based on the most up-to-date literature and research. And they have some good resources that are free, as well as if you wanted to join the organization, it's a great supportive community. You can, there's forums, you can ask questions. It's just a bunch of passionate, like-minded, helpful, brilliant people. They actually came out with a guideline in September of 2024 that was free for everyone, including patients or providers alike, particularly about lichen sclerosus. And that can be downloaded, and it's an awesome guideline. There's other organizations such as the Vulvar Dermatology Research Consortium that can be helpful for providers who are particularly interested in research and wanting to get involved in that. And then things like the International Society for the Study of Women's Sexual Health is another wonderful organization. There's the Vulvodynia organizations, but by and large, the organizations that I would probably point people towards would be ISSVD and VDRC.
Well, excellent, folks. You heard it here. That's where you can go to get some support. And thank you, Audrey. I think we got a lot of great tips on how to really address this issue that sometimes is uncomfortable, even for the most seasoned of dermatologists. So thank you, Audrey, again, for your time, for your expertise, and for really
great, Audrey.
Yeah, for really shining a light into an area that really I think is underserved and really requires special attention. Sort of being mindful of that as you go to every patient's room. So, thank you for your time, your expertise, and thank you, Raja, for joining me as well.
Thank you. It's a pleasure.
And that's a wrap for today's episode. But Raja, every time we dive into these conversations, it feels like there's still so much more to uncover.
Exactly, Hadar. That's why I look forward to IDS every year. It's the perfect place to continue exploring the latest in research, sharing ideas, and learning how to apply integrative strategies in real-world dermatology practice.
And this year's theme couldn't be more relevant. Guide your patients towards a healthy biome and optimal skin health. We know that skin health isn't just about treating the surface. It's about understanding the biome and how it connects to the overall health of our patients.
And that's exactly what we'll be tackling at the 8th Integrative Dermatology Symposium happening August 21st through the 24th at the Westin La Paloma Resort and Spa in Tucson, Arizona.
Now, we've got an amazing lineup of expert-led sessions covering key dermatology conditions like eczema, psoriasis, vitiligo, alopecia areata, and melasma, plus insights into how movement, weight loss, and even coca polyphenols can impact your skin health.
Now, who doesn't want some good cocoa polyphenols? I know you do, Hadar. Your food addictions. And what really makes IDS special is the interactive format. It's not just about sitting through lectures, and we really make that a point. We'll have real-world case discussions, hands-on workshops, and plenty of opportunities to connect with colleagues who are just as passionate about integrative dermatology as we are.
And folks, let's not forget about the location. The Westin La Paloma Resort and Spa. That's the perfect place to learn and recharge. And you can relax by the waterfalls, stargaze under the Arizona sky, play around a golf or tennis, or unwind at the spa. And of course, we'll have evening receptions where you can catch up with your colleagues and make new connections.
Now, who doesn't want to go stargazing and whisper sweet integrative everythings, not nothings, Hadar, to each other? Now, that sounds like the ideal way to learn, recharge, and connect all in one weekend. And if you haven't already, head over to integrativedermatologysymposium.com to check out all the details and save your spot now.
That's integrativedermatologysymposium.com. And as a special thank you to our podcast listeners, we're excited to offer 15% off your IDS registration. Just use the code podcast15 when you sign up. Simply head over to integrativedermatologysymposium.com to register. We can't wait to see you at IDS 2025 in Tucson, Arizona. Let's take integrative dermatology to the next level together.